Okay, why don't we go ahead and get started? Bob Wachter, Chair of the Department of Medicine. Welcome to UCSF Medical Grand Rounds. If you think about it, the departments of medicine basically own all of the organs of the body except one, and that is the brain and the neurological system. But we are incredibly fortunate at UCSF to have the world's best neurology department, which we depend on all the time as partners in our clinical work and our research and education. And that is the topic of today. We're going to be talking about common neurological problems, changing directions, and update for internists. We're thrilled to have as a speaker Mark Terrelonge, who is Associate Professor of Neurology and Associate Program Director of the UCSF Neurology Residency. Mark went to undergraduate school at Harvard, went to Stanford for medical school, and we were lucky to recruit him to UCSF for his residency in neurology and then fellowship in neuromuscular diseases. His work now, he focuses clinically on disorders of the nerve, muscle, neuromuscular junction, and spine. He also takes care of general neurology patients at the county and also in some of our regional centers, including in Fresno. He has a special interest in patients from rural and underserved areas of California, and he's really been a wonderful go-to resource for many people in our department. So Mark, thank you for being here. Look forward to hearing you talk.
Good afternoon, everyone. So today I'll be talking about common neurologic problems and some updates for internal medicine. And our goals today are going to be to identify any recent changes in the evaluation and management of some common neurologic problems that are relevant to internal medicine practice, and then think about how some early management decisions change to be able to help reduce either unnecessary testing and treatment, and then what parts can be owned by internal medicine versus neurologists. So I've tried to make everything today I am relevant, but because I do like to add some neurologic flavor to a few of the slides, for some things that I think are neurology specific, I put a little brain icon to say, this is interesting to note, but doesn't necessarily need to be something that we're going to focus on for today. So these are the 10 most common neurologic diseases that you'll see either in both inpatient and outpatient practice. The two that I chose to focus on for today's talk are going to be headache disorders and then cognitive disorders and dementia, largely because from polling many internal medicine and family medicine colleagues, these are where, because of a lot of practice changes that have happened over the past 3 to 5 years, both in terms of inpatient and outpatient management, that we thought that we could probably discuss the most. So with that, on our first case, I'm going to call it a cognitive turning point. So our first patient is Miss L. She's a 72-year-old woman with an 18-month history of progressive memory complaints, word-finding difficulty, and executive dysfunction. She's noticed a gradual onset of these thinking changes for about the past year and a half. She thinks they've been progressive, but she still is able to do all of her daily function. She does feel like she has some increased reliance on her spouse for finances and appointments, but otherwise is able to mostly do it on her own. In terms of risk factors, she has hypertension, hyperlipidemia, family history of dementia. She's originally from London. She has no history of smoking, and she drinks 1 to 2 drinks per week. Then on her exam, she has an MMSE of 24 out of 30, a MoCA of 22 out of 30, and in both tests, she really failed a lot in the impaired recall, and then also executive function tasks. And then she had a normal neurologic exam otherwise with no focal deficits. So her first question to you in the primary care clinic was, how do I know if this is normal aging or something more? And for normal aging, once people become older, usually around 65 or 70, it's normal to have some word finding difficulty and potentially slower recall. But even with that, most people will still have preserved function in terms of their ADLs and IADLs and independence. MCI, or mild cognitive impairment, is whenever a patient has objective cognitive decline on testing, either one of the tests that we've described before or other neuropsychiatric testing, but they still have preserved independence and they have an increased risk of dementia once they cross into this stage. And then for early dementia, this is the same thing of having a cognitive decline, but instead now having significant functional impairment in an IADL, often with insight loss into this change also. The one other category that's come up more, it's been discussed more in the past 5 years, is this thing known as subjective cognitive decline. This is when a patient feels like they have self-reported cognitive decline without objective deficits on testing. And this usually does not progress There are a few patients who this could be an early sign of something like Alzheimer's or another disease, but usually reassurance and even neuropsychiatric testing and testing over time is enough to be able to help people know that generally that they may be in still that normal aging group or a little bit below their baseline. Thinking about ADLs, we have the basic ADLs and then the instrumental ADLs or the IADLs, which include finances, medications, cooking, shopping. Whenever we're thinking about dementias and cognitive impairment diseases, we usually are most concerned that first patients will lose their IADLs, and only once the disease becomes much, much more advanced will they start to lose their basic ADLs. So given her testing with her low MoCA, but her ability to do most things on her own, she says, okay, you think I might have mild cognitive impairment. Is it reversible or is this something more concerning? There's usually a tier 1 group of tests that we do whenever someone has thinking changes. These include a CBC, a CMP, a TSH, and a B12. And then depending on the population that you're working with, sometimes doing some form of syphilis testing or HIV testing could be indicated, but is not necessary in all patients. And we generally like to avoid low yield tests such as ESR, ANA, heavy metals, or Lyme. Usually if they first are presenting in a primary care office, you have the luxury of some time to be able to see how they progress over time to understand if it's something more concerning or less concerning. Neurologists sometimes in clinic may do more testing, but that's because we may only see the patient once or twice and are trying to do more sometimes in that one visit. There's differing guidelines on what imaging is necessary whenever someone comes in with cognitive complaints. Some say a CT is fine, others say an MRI is fine. But usually I think about what image is going to be helpful for ruling in or ruling out specific diseases. For things that you're trying to rule in with your first image are specific neurodegenerative conditions. For example, if someone has Alzheimer's disease, we might see atrophy of their hippocampi on MRI. Or if they have something like vascular dementia, we can see increase in white matter changes throughout the brain. Then separately, you also want to rule out specific things such as structural lesions, strokes, hemorrhages, or things like a subdural hematoma. Usually for an MRI, there's a few things that are red flags that say that they should get an MRI if they're having cognitive complaints. Usually if their age is below 60, they have focal findings on neurologic exam, their symptoms have come on quite quickly, they have any history of trauma, or they have cancer, other systemic illness, or medications that can increase the chance of injury to the brain, things like methotrexate or the like. So some time passes, and she returns with her husband 1 month later, and her husband remarks that she's been repeating the same stories during dinner and has had increased difficulty with managing her finances, and that they've had 2 missed bills. She had her BMP, CBC, TSH, and B12 return as normal. And then on her MRI, she's found to have symmetric medial temporal lobe atrophy, parietal volume loss, and nothing else that was concerning for something that was Alzheimer's type neurodegeneration. So she comes back to you and says, I saw the MRI report and I'm worried. Can we confirm whether this is Alzheimer's disease or not, just based on that MRI and some of the testing I've had? So thinking about dementias in general, there's 3 that are by far and away the most common, and those are going to be Alzheimer's disease, vascular dementia, and Lewy body dementia. When you're thinking about people who are below the age of 65, frontotemporal dementia, different dementia becomes a little bit more common. But above 65, about 90% are going to be in those 3 categories. There's different hallmark clinical features that happen in these categories. With Alzheimer's disease, because it's an atrophy of the parietal and the temporal lobe, usually memory impairment is the main thing that people will notice first, along with word finding difficulty. For vascular dementia, we oftentimes talk about this as being a stepwise decrease in functioning and executive functioning. The way I oftentimes think about it is if you had information you're trying to get from area A to area B, you could have 100 nerves that are connecting that. But if you have little tiny strokes that keep whittling away at that, you can go from 100 to 50. There's a lot of redundancy in the system. The patient doesn't notice anything. 50 to 25, still some redundancy, but it might slow down a bit more. But when you go down from like 25 to 10, then the system really starts to break down. So even though they're accumulating these strokes in a linear fashion, there's a certain cliff that they might go over where they can have a pretty big decrease, which is why they notice these stepwise decreases. For Lewy body dementia, this is related to things like Alzheimer's disease, but patients will have cognitive fluctuations where they can have full attention one moment and then very low attention another moment. visual hallucinations. Frequently, they'll see very well-formed hallucinations of things like children, or they might notice shadows moving around in the dark or shadows around the corner of their eyes, and they may have some Parkinsonism. And then there's imaging findings for each that can help with thinking about whether that might be the correct pathology. When I was in med school, and I think still now, the only way to say that someone definitively has something like Alzheimer's disease is to get pathology. And you're normally looking for these plaques that contain A beta 42, or these neurofibrillary tangles that contain 3,4 tau. However, we luckily over the past 15 years have developed many other tools to be able to look for similar without having to get a piece of brain. And some of these tools that they may get in the neurology office include things like an amyloid PET, where we're able to see where amyloid plaques are deposited throughout the brain. There's other types of PETs that look at other proteins, but something called tau, or we can just look at the metabolism of the brain and see which parts of the brain are working more or less and see if it's in an amyloid type pattern. There's also CSF studies that we can look at for those two proteins, both tau and then CSF A beta, with usually if the A beta is getting locked up in plaques in the brain, it'll actually become lower in the cerebrospinal fluid. And then as people progress through Alzheimer's disease, they get more phosphorylated tau that's available in their CSF, so those levels go up. And the reason why this is important is that just this past year, the FDA has cleared its first blood test for diagnosing Alzheimer's disease. I'm just curious if anyone in the audience has sent this blood test yet. Okay, so it's being used in many, many different settings. And what it does is it takes both the phosphorylated tau and the amyloid beta 142 and divides them to be able to create a value that corresponds to whether somebody's amyloid PET and whether they're more likely to have an amyloid PET study that's positive or an amyloid PET study that's negative. So it measures this ratio. It's non-invasive. It's a simple blood test, and it's available even since May pretty commercially at many, many different labs, including commercial labs. And it's not intended as a standalone diagnostic test. It really needs to go along with a lot of the other information that's in the patient's chart. In the primary setting, which would be the PCP office, it's been found that in patients who there is concern for amyloid, it has about an 82% positive predictive value for identifying Alzheimer's disease and about an 88% negative predictive value. And then within a neurology office, it's slightly higher at about 89 to 95%, with about the same negative predictive value. There are a lot of caveats to this test, and I think that people are starting to use it and asking more questions about it. But a few things to note is that the levels of these biomarkers are affected by chronic kidney disease. In particular, it can drive up the phosphorylated tau and can lead to false positive results. Phosphorylated tau also has lower levels in Black or African American patients, which can increase the risk of false and negative results. And then in some real world data that we've seen outside of the trial, in the trial, you get the blood test, it goes to the same lab, it's processed the same way. But whenever you have labs across the country using this, one thing that A beta 42 is a very sticky protein. It can stick to itself and it can stick to the outside test tubes, and that can cause it to artificially go down. So in many labs, there's been an increase in false positives. The Mayo Clinic has noticed this and other labs have noticed this too. So I think that there's going to be more quality control over the next year to be able to help make sure that the test is maintained its sensitivity and specificity and positive and negative predictive value across settings. Additionally, this is not sufficient to start anti-amyloid therapy, which we'll talk about in a few slides. So with these new tests, they are very exciting, but they still will require additional workup. But if the patient is interested in a definitive diagnosis, a referral to neurology is appropriate. And if there's any doubt in terms of what disease they may have, for example, if they have a vascular dementia picture plus Alzheimer's disease, this test could certainly be helpful in helping triage the next steps. So in most parts of pretty much everywhere, the patient says, I'm interested in seeing neurology, but I won't be able to see them for 6 months. So what therapies can I consider now if this is Alzheimer's disease? And along those same lines, with AD pathology, we normally think of the pathology as injuring the nervous system, and then that injury then leading to symptoms. And then as the disease progresses, people accumulate neurologic disability and have decrease in their MMSE or their cognitive decline. But we have some medicines that can help symptomatically, essentially keep them on the same trajectory, but increase how well they're doing. That helps with symptomatic effect. And then now we have medicines that are disease modifying, which can change that trajectory overall, which we'll discuss. For symptomatic AD management, if you have a patient who has only mild cognitive impairment, which means that they have no functional decline, while there is no strong evidence that any medicine is helpful in this case, including the anticholinergic medicines. However, once they transition towards having dementia, meaning that they have some issues with their activities of daily living, then we start to use these medicines that focus on the deficit areas that accumulate in the brain. One of them is the cholinergic cells, which decrease in AD and actually in many different dementias. And we oftentimes use cholinesterase inhibitors to be able to help, including donepezil, rivastigmine, and galantamine. And then the main things that you're looking for with this is that those all have a lot of cholinergic side effects. I always tell people it makes things run and it makes things wet. So the heart gets slower, but the GI system increases. They can have fasciculations or twitchings of muscles, cramps, increased saliva as side effects from those. Whenever people have moderate to severe Alzheimer's disease, we'll oftentimes start a medicine like memantine, which is stops glutamate-induced neurotoxicity. And this medicine has a lot of evidence when looking at patients over time to decrease their risk of having to go from home to a nursing home. And it can oftentimes delay that by 2 to 3 years. So there's good evidence on both of these that these can be both helpful for thinking and in terms of people being able to do their ADLs and IADLs. The newest therapies that have come out since around 2021, even though the one that we still have now came out in 2023. These are anti-amyloid beta immunotherapies. And these are ones that have been either in trial or have been approved. And the three in the boxes, lecanemab, donanemab, and aducanumab, have all been approved, even though aducanumab has been pulled from the market because it was approved on clinical phase 2 data, but not the phase 3 trial didn't pan out with the same result. But lecanemab and donanemab are currently available. So lecanemab was approved in 2023 for patients with early AD, and they have to have confirmed amyloid pathology. It's a humanized IgG monoclonal antibody that targets clearing of amyloid beta protofibrils in the brain. And it does show a modest slowing of cognitive decline in clinical trials. The main trial for this was something called Clarity AD, and it showed it was able to slow down disease by about 25 to 30%. There's actually additional data looking now that recently came out at 36 months that shows that this difference is maintained. Another medicine that came out, donanemab, as we'll talk a little bit about how it's different, also showed similar effects. So the patient says, we still have 3 months to see a neurologist. What should I be prepared to talk about at this visit? I think I want to start those therapies, but will I be allowed to? So, and I think this is something that people can talk about with their patients before they come to neurology. The inclusion criteria of this is that the patient has to have mild cognitive impairment or mild dementia due to AD. So they don't have to have dementia yet. We actually are able to start this medicine when they're in the mild cognitive impairment stage. They have confirmed amyloid pathology, and this does require either CSF or the PET scan. And they have MRIs without any microhemorrhages or cerebral amyloid angiopathy. Cerebral amyloid angiopathy is when amyloid deposits in blood vessels and increases the risk that they can break open and cause microbleeds. The exclusion criteria is moderate to severe dementia, significant cerebrovascular disease, or if they're on anticoagulation or have a few other things that we sort out in the neuroclinic. The cost of this medicine, about $30,000 a year. Traditional Medicare will cover about 80%, but the other 20% comes from out of pocket or from supplemental insurance. And then there's additional costs associated with this because patients require several MRIs and lab tests as they're going through this therapy. And to give a sense of, for the two therapies, what patients may have to do time-wise is it's an IV infusion, about an hour, that they get every 2 weeks. And in the first year, and even in the first 6 months, they require 4 MRIs to look for one of the main side effects, which I'll go over in a little bit. So it is a large cost, a large time commitment, and it's only done at certain centers where there's nursing that's able to give this infusion and then also be able to follow up that patients aren't having any of the side effects. So the patient does decide to meet with neurology, confirms with an amyloid PET that this is Alzheimer's disease, and discuss the cost and benefit of different anti-amyloid therapies, and goes through the site's amyloid therapy board, which many academic centers have been using now to be able to help determine who's appropriate for this, and they're deemed eligible, and they begin therapy with lecanemab. So fast forward 2 months, and they choose to come to this hospital here. And in the ED, she's brought by her daughter for acute confusion, headache, and refusal to eat for the past 2 days. She had pretty acute onset agitation and worsening confusion that was superimposed on her baseline memory deficit, and she had new trouble with walking. She has no fever, no vomiting or recent travel. She took a donepezil dose about 3 days ago. She has mildly high blood pressure, but otherwise is afebrile and satting well. Her neuro exam, she's alert, but she's confused about time and place. She actually has a left-sided pronator drift, and she has gait ataxia. Her lab's looking for other things that could be contributing or negative, including a negative UA. And she has a head CT that shows chronic microvascular changes and a questionable small region of increased hyperdensity in the brain. They go forward with getting an MRI. And on the MRI, it's seen that over her right frontal parietal lobe, she has significant vasogenic edema. And then she has multiple new microhemorrhages in many other parts of the brain. No evidence of any big ischemia or mass. And she is diagnosed with amyloid-related imaging abnormalities, or ARIA. So with that, what is ARIA? So sorry for the Game of Thrones fans, they'll get this. So ARIA is amyloid-related imaging abnormalities that are the most important side effect that patients can get with anti-amyloid monoclonal antibodies. And there's two main types that patients get. ARIA-E, where they get edema or effusions, and then they have edema essentially in one part of the brain, essentially the part of the brain where the anti-amyloid therapy was likely working well, or they could have hemorrhages. The other thing that they can get is superficial siderosis, where iron deposits over the top of the brain. And all of these things can lead to things like headaches, confusions, focal deficits, seizures, or gait instability. There are certain people, particularly those who have a certain ApoE subtype that increases their risk of having Alzheimer's in the first place, who may have a higher chance of getting this type of ARIA. For lecanemab, about 21% of patients get it. For donanemab, the one that's only once a month, about 30% of patients get it. Whenever patients get ARIA, it's usually graded as mild, moderate, or severe, but not all ARIA is dangerous, and we really make the determination of whether we're going to treat it and how to treat it based on the patient's symptoms. And the therapy may or may not be restarted afterwards. In this patient's case, she was diagnosed with both ARIA-E and ARIA-H related to her lecanemab. She was started on IV dexamethasone to help reduce the cerebral edema, and she had gradual clinical improvement over 5 days and was discharged with close neurology follow-up. And just to say that this type of side effect from these therapies for lecanemab is seen in about 2% of patients, and then for donanemab, the one that's once a month, in about 6 to 7% of patients. So the family comes back to their PCP and they say that they chose not to continue with lecanemab therapy due to the long-term cost, time, and concern for benefit. They didn't get sometimes after lecanemab or after a few infusions, patients will get a PET to see if their amyloid has been decreased. They chose against that, but they did choose to continue on donepezil. So thinking about why this case, there's a few things that I think it highlights that are important for internal medicine and neurology. One is that cognitive complaints live on a spectrum. We talked today about subjective cognitive impairment being a new thing that has been described, where patients, it helps affirm their feeling of loss of cognition, but it has some stable data to suggest that they won't progress to something more severe. We also talked about MCI and dementia. We talked about the high yield workup and imaging that's helpful for different types of dementias. We talked about that common dementias are still common, with vascular dementia, Alzheimer's disease, and Lewy body making up about 80 to 90% of the pie. That the new blood biomarker test that has come out is a tool, but it's not a full answer and has to be read in the context of the rest of the patient's chart. That symptomatic therapy still matters. Things like donepezil and memantine have a lot of role in Alzheimer's disease. That anti-amyloid therapies are changing the conversation. They require a lot of time and they're expensive and they have risks. I think that people thought this was going to be a magic bullet that was going to change Alzheimer's disease care all at once, but it's really in a select group of patients who may have benefit, even though new kinds are being developed, which will hopefully have less side effects and more chance to be able to be used outside of academic centers. So for case 2, the first migraine is the hardest: inpatient evaluation and outpatient escalation. Here I have Miss H, who is a 39-year-old woman who's admitted to your service with rapidly spreading cellulitis for IV antibiotics. On day 2 of her hospitalization, she begins having a headache. She notes a severe unilateral headache that began overnight about 12 hours before you've rounded. And the pain is described as throbbing. It's associated with photophobia and nausea, and it's worsened with activity. She's never had a headache like this before. And she's tried Tylenol and ibuprofen overnight with no improvement. She denies any trauma, fever, any neck stiffness, nor any focal neurologic symptoms. And her past history includes hypertension and obesity. She has no autoimmune diseases and no hypercoagulability history. Her vitals are stable, and her exam is non-focal, and she has the cellulitis. So the first question that comes up is, what type of headache is this? And here I put the International Classification of Headaches Disorders definition of headaches. I think it's probably the most straightforward. There's three main types of headaches they describe: primary headaches, secondary headaches, and then painful cranial neuropathies. And among these, primary headaches are the most common. And among the primary headaches, migraine and tension type headaches are the most common. So what is a migraine? We'll do it first by definition, then by pathophysiology. It's a patient having 5 or more attacks that are 4 to 72 hours. They have to have 2 of these 4 qualities, either unilateral, pulsating, moderate to severe intensity, and then aggravated usually by physical activity and improved with laying down, and then usually 1 or more associated feature, either nausea or vomiting, or photophobia or phonophobia. And this patient truly has all of these, but she's only had 1 of them, so we don't call this a migraine. We would say this is a migraine-like headache. Comparing it to tension headache, the only two, you'll see a lot of charts describing the difference between the two. Migraines can sometimes be on both sides. Tension headaches can sometimes be more on one side. The quality of the headaches can sometimes switch. The severity, you can have mild migraines, you can have really severe tension headaches, but the things that really do help separate them are the nausea, vomiting, and the phonophobia, photophobia, which really should be present with a migraine and really is one of the more distinguishing features that we think about. So for her, after you think this is a migraine, the next thing that you want to wonder about is, is this still going to be that primary headache that you're thinking about? Given it's a new headache, could it be a secondary headache? And then what are the red flags for secondary headaches? There's lots of different types of tools or systems people use for this, but I have this little girl looking out with binoculars to help people remember SNOOP4. Has anyone else heard of SNOOP4? Do people use SNOOP4 here? You might see SNOOP10, you might see SNOOP1. I think SNOOP4 is the right number, and we'll go over each of these. So first S is systemic signs. Usually this suggests something inflammatory, infectious, or malignant that could be affecting the CNS. It usually hints at some blood-brain barrier disruption or systemic cytokine activation. What you're considering when you bring this up is CNS infection, malignancy, or vasculitis. And once you have one of these secondary symptoms, it's perfect if you're on the inpatient setting. Calling neurology to get additional recs for imaging is certainly appropriate. In this case, you definitely want to get an MRI brain with and without contrast. And as an example case here, this is a patient with an abscess that may be seen if they have other signs of systemic infection, if it went to the central nervous system. The N of this is neurologic symptoms. It usually reflects focal cortical, brainstem, or cranial nerve involvement. It indicates something structural, vascular, or even epileptogenic that could be a pathology contributing to the headache. You normally want to think about stroke or mass lesion or seizure. And then for this one, you want an MRI brain. But if it's an emergent case and it came on quite quickly, you're in that stroke code or code stroke kind of mind. So you're going to want to get a CT to make sure that you're not missing something that might need to be dealt with urgently. In this case here, we have a hemorrhagic stroke occurring in the patient's left parietal lobe. O, onset sudden. I know it's backwards, but it works for the acronym. So in this case, you're concerned about a patient having a rapid rise in intracranial pressure or an acute vascular event. Usually the big thing that we're worried about here is an aneurysm that has ruptured, or even if they don't have an aneurysm, a blood vessel that has torn and has suddenly increased pressure on the subarachnoid space. It usually suggests meningeal irritation or an arterial rupture. Usually the thing that you're trying to rule out, subarachnoid hemorrhage, subarachnoid hemorrhage, subarachnoid hemorrhage. But other things that we think about are reversible cerebrovascular vasoconstriction syndrome or cervical artery dissection. One other thing I'll note on this is that we oftentimes use the term thunderclap headache for this, but the headache does not have to be the worst headache that they've ever had in their life. The other thing that we talk about is the tempo of the headache. Sometimes some people will say it gets from 0 to 100 in a snap, but if it happens in a minute, that's still way too fast. Even 2 to 3 minutes, it's way too fast. most headaches build up over about 30 minutes to an hour. So both of those would still qualify as this onset sudden type of headache. For this, you're going to want an emergent image with a CT and a CTA, possibly with an LP, to be able to look to see if there's any blood in the cerebral spinal fluid. And this is an example of a CT scan where this patient has blood or the bright material throughout all of the basal cisterns because of an aneurysm rupture. And this is probably the most deadly thing that's on the differential for the SNOOP4. The next one is older age at onset. The reason why this one matters is that the chance that it's a secondary headache increases once people are above 50, or that it could be due to a vascular or neoplastic disease. There's very few people do get migraines that start in their 50s, but it's pretty rare. The other thing that comes up on this differential is giant cell arteritis, where about 45, 50 is about when this starts to enter into the differential. And that is dangerous because that can lead to sudden vision loss because of similar to as a vascular process, it can lead to sudden vision loss. Usually for this, you want an ESR-CRP, an MRI head and face with vessel wall imaging versus an ultrasound of some of these vessels. And when you do the MRI head, you can actually see here, this is a patient with giant cell arteritis, their left temporal artery, which is about right here. The two little green arrows show that it's a lot larger on this patient's left side compared to the right side, and can be helpful for if you're trying to do biopsy confirmation for thinking about this and thinking about next steps of treatment. The P is for progression. And whenever you see this P, it indicates evolving structural, inflammatory, or pressure-related pathology. Usually you're thinking about things like a tumor, subdural hematoma, or chronic infection, and you want an MRI brain for this. This is a patient with a glioblastoma multiforme, which may be normal, but once it obliterates the third or fourth ventricle, it can increase pressure and lead to diagnosis. The next P number 2, is papilledema. This usually shows a sign of sustained elevated intracranial pressure, and it reflects impaired CSF absorption or mass effect. You're normally thinking about mass lesion here, idiopathic intracranial hypertension, or cerebral venous sinus thrombosis. And you want an MRI, an MRV, or a CTA, CTV. And just as an interesting thing that we can frequently see on MRI, oftentimes we have patients who have papilledema that we'll see in clinic, and we wonder whether it was present earlier or at another time point to be able to get a sense of how old it might be. And you can see actually even on MRI, whenever patients have papilledema, in the back of the eye, you can actually see the optic nerve pooch forward. Next P, positional or Valsalva related. That usually indicates some kind of pressure-dependent change or altered CSF dynamics. If the patient has the headache worse whenever they sit up, usually suggests that they might have a low pressure headache. When you sit up, your brain sags if you don't have enough CSF production or enough CSF in the brain, and that sagging of the meninges is what leads to the headache. If the patient lays down, then that can point to a high pressure headache, and that usually has to do with either impairment of CSF absorption, too much CSF production, or mass effect. Notably for the positional ones, whenever people are laying down, it doesn't have to be that they need to lay down and the headache suddenly gets worse. The more frequent thing that they'll note is that they wake up in the middle of the night with a headache, or they have headaches in the morning, with the idea being that they've been under the higher pressure throughout the night or for hours and hours, and then they'll have the headache. So it doesn't have to happen right away in clinic. If it does happen in clinic, if you have them lay down and it suddenly gets worse, that's probably more emergent. For these, you're considering things like Chiari malformations or mass lesions for the high pressure headache, or a CSF leak for the low pressure headache. And in these cases, you may need an MRI brain plus or minus MRI spine, especially if you think about low pressure phenomena, which can happen sometimes if people have had prior lumbar punctures and have a leak, or other pathologies in the spine. And this is a picture of a patient with a Chiari malformation. The last P to know is going to be for pregnancy. And pregnancy can lead to a hypercoagulable state, and also an endothelial stress state where fluid can quickly leave from the endothelium into the brain and cause edema. It increases susceptibility to vascular and pressure-related pathologies. So we think about cerebral venous sinus thrombosis on the hypercoagulable side, preeclampsia and eclampsia on the blood vessel edema side, and then RCVS on the blood vessels closing side. So for this, you usually want an MRI, MRA, and MRV. And this is a patient in this picture with eclampsia, who has additional edema in the back of the brain, which can cause headaches, can cause seizures, can cause vision changes, or other symptoms. So for our patient, she has cellulitis. We don't even, as long as there's no other extremely abnormal markers, we wouldn't think that's a big red flag. So we said that she had no red flag symptoms, but given it was her first headache, the team did get a brain MRI, which was read as normal, and thought that she might have migraine-like headaches. So she wants to trial a medication to stop her headache after trying both the Tylenol and the ibuprofen. And then for inpatient migraine management, the two best first-line therapies are going to be IV prochlorperazine or compazine, and then also a greater occipital nerve block. To the point now that the American Headache Society has said that for any patient who goes to the emergency department with a headache, that they should get both compazine and a GON block right away. And I'm just wondering, has anyone had any patients who've gotten GON blocks in the ED? So very, very department specific, or not department specific, institution specific. Many East Coast institutions, if someone comes in with a migraine, it's the medicines and GON blocks, even done by ED providers in the emergency room, but it's picking up steam across the country. The other things that are in this first line group include IV ketorolac or other IV strong NSAIDs, IV fluids, and then we give Benadryl too, or diphenhydramine, mainly to stop the akathisia or the movement feeling people get from starting the prochlorperazine or metoclopramide. For second line therapies, we sometimes use IV magnesium. Steroids can usually stop most types of headaches if you give them in high doses. Valproic acid, even though there's a lot of caveats for that, especially for women of childbearing age. And then triptans can sometimes be used, but usually triptans need to be used really at the beginning of the headache. If the headache has already started, you might have lost the window for it to be most effective. Supraorbital blocks are also used. Where we are lacking evidence, we know that IV hydromorphone is not effective. Opioids in general, we try to avoid, but in some people's headaches, they do work, but we try to avoid them, definitely not after any of the other things. Propofol and IV Tylenol don't have a lot of data that support them. And then we're still a bit inconclusive on things like ketamine, caffeine, and then another class of medicine, the CGRP monoclonal antibodies that I'll discuss in a little bit. So she's given IV compazine, ketorolac, IV fluids, and Benadryl, and her headache reduces by 70% in 2 hours, and she's discharged from the hospital the next day for cellulitis with oral antibiotics. Over the next 6 weeks, she develops more frequent recurrent headaches, now occurring about 8 to 10 times per month with continued migraine features. She has no new neurologic symptoms, and she calls urgent care, who provides her with an oral triptan medicine, which she's tried with some improvement of her headaches. But she comes to her PCP office asking, I'm having headaches so frequently, do I have migraines? And what can I start to limit the number of headaches I'm having? So a few other definitions. We talked about migraine, but episodic migraine is what we say, what we call somebody who has less than 15 headaches per month. Chronic migraine is more than 15 per month for about 3 months. And then status migrainosus is if it lasts for greater than 72 hours. For therapies, we usually try to put them into 3 main buckets. First, lifestyle, second, abortive, and third, preventative. And we usually think about it in that order, first starting with the lifestyle ones. There's many patients that we'll hear about who say, I work night shift all the time. I've tried every medicine, and I sleep 2 hours a night. And they've gone well down the medication pathway, but not on the lifestyle one. And a small lifestyle change can change everything. So things that we tell them about are adequate sleep and regular sleep. Don't skip meals, drink water, keep headache diary, and to do regular exercise. We oftentimes don't only say this because that will make some patients very upset that they were waiting for a neurology visit and we just give this back to them. Stress reduction and avoiding known triggers, we discuss, but we tend not to overdwell on because we don't want to put blame on the patient for their headaches. But usually, often we're going to be starting a prescription medication for migraine also. And there's these different classes here for which we have both acute medicines and the preventive medicines, and then some medicines that can actually cross into both. The biggest takeaway from this slide, and the biggest point I hope to go over in terms of migraine management, is that for acute meds, the very first sign of any headache that they have, the aura, the second that they feel even just a little bit tired or whatever their prodrome is before they have the headache, they should take the medicine. And oftentimes during neurology visits, if they have headaches, we'll always ask, is there anything you notice before the headache? Because getting them the medicine before it starts can actually help keep it down. and many patients will have a prodrome of either fatigue or tiredness or something else before it starts. The other thing on the preventative medicine side is that we want them to take it for 2 to 3 months to be able to see if it's effective. Going over abortive therapies, ibuprofen is the first one that we recommend to most patients, 600 milligrams oral, first sign. Triptans can be very helpful for migraines too. These are serotonin receptor agonists that work on both smooth muscles and nerve endings and help stop the migraine cascade from continuing. You usually tell them take 1 dose at symptom onset and they can repeat another dose 2 hours later. It's contraindicated in people who have coronary artery disease, prior stroke, or a specific migraine type called hemiplegic migraine because it can lead to some vasoconstriction. For triptans, there's many different types and many different formulations. You can take them orally. You can take a version that you do as an injection. There's a version that you can take that's a spray in the nose. Really, the main thing to note is that there are many types, so that if a patient fails one, they can try a different one, and that there are some that work slightly faster depending on their how they've done with the past one. Additionally, there's another category that is similar to triptans known as the ditans, which only work on one of the serotonin receptors and can be used in patients who have had coronary artery disease or remote stroke. The 2 other classes we think about are antiemetics, and then more recently, the CGRP small molecules, with CGRP standing for calcitonin gene-related peptide. Calcitonin gene-related peptide is something that has been discovered in about the mid-2010s that is a molecule that plays a huge role in migraine pathophysiology. It activates mast cells, it opens up the blood vessels near the meninges that can actually be quite painful, and continues on the cascade that comes from the trigeminal network that actually leads to a lot of the pain symptoms of a migraine. And since about 2017, but much more commonly used since about 2020, we've been trying to block this pathway as the most specific way to be able to help stop migraines. So 2 main classes of medications. One are the CGRP monoclonal antibodies. These are very large molecules that don't cross the blood-brain barrier. They act slowly, but they last for a long time on the orders of weeks to months, and they either can target the CGRP ligand or its receptor. And then the other molecules that we created are something called GPANTs, which are small molecule CGRP receptor antagonists that can partially cross the blood-brain barrier. They're oral and they're rapid, and they're primarily for fast-acting headache management, even though they can be used in another context too. There's the number of these has been slowly increasing over the years. Atogepant and rimegepant are probably the 2 most common ones. So Nurtec is the one that many people may know of. Depending on where you work or what's on your formulary, some or more or less of these are available. Usually, you take one at the very first sign of a migraine. The good thing is that these don't cause any vasoconstriction, so they can be used in patients with coronary artery disease and stroke. They are CYP inducers and inhibitors, so you have to be very careful of what medicines you use with them, but they can also be used in patients with moderate hepatic or renal disease. In severe, you have to use caution, but they can be used in a large group of patients. There's no adequate data in pregnancy, so you only use them if they're absolutely needed, and we caution them in lactation. There are a few of them that can be used also for prevention, in particular rimegepant and atogepant, though we sometimes will caution patients against using these first line for prevention, given that they can be used really well as an abortive, so to keep them in that class and to try something else for prevention. For when we think about starting prevention, I think these are the main criteria that we've discussed with patients. One is if they're having an attack more than once per week, if they're using acute medicines more than twice per week, if it's causing for any reason activities with their difficulty with life despite taking medicines, if they have any elevated risk of medication overuse headache from use of any daily medicine, or if the patient wants it. Most patients don't come to clinic wanting to take a medicine, but if they really want one, we will generally start it. I put this slide up for reference just to say there's about 35 medicines that can be used for prevention, but big picture is that nutraceuticals are good for patients when they want to minimize medications. These include things like riboflavin 400 milligrams daily or magnesium oxide. Other beta blockers, valproic acid, and Topamax are considered the first line medicines, but As many of you who have worked in primary care may note, there's a lot of side effects with all of those. Beta blockers make people feel fatigued and tired, maybe even depressed. Topiramate is also known as Topamax, has another name, Dopamax, because it makes people feel very cognitively slowed. And then valproic acid is very dangerous for anyone who's thinking about getting pregnant. So, and also affects almost every medicine. So more frequently, we see people start tricyclic antidepressants. Those have anticholinergic side effects. The patient will definitely get them, but they can be quite beneficial at lower doses of around 10 to 50 milligrams. There's a frequent go-to first medicine in our practice. Many second-line medicines are matched usually by patient's concurrent risk factors, and that certainly is a great reason to send a patient to neurology to think about other medicines to try. The new kids on the block are these CGRP monoclonal antibodies, which are those big molecules that I described that don't cross blood-brain barrier, but can stay in the system for months. There's 4 main ones that we use now that either can target the receptor or the molecule. And really, to be able to place someone on them, they only need to have 8 migraine days per month. They can have 2 headaches that are 4 days each, and they hit that 8 days, as long as you document 8 days. And even in some places, 4 days is enough too. There's insurance plans and regional guidelines that some will allow PCPs to prescribe this, others require neurologists to prescribe this. It's always helpful to know which ones you might be able to prescribe directly from a PCP office rather than having to have them go to neurology. Sometimes that they're gated, that one can be done at a PCP office and another one through neurology. Main side effects from these are injection site reactions. Some patients get constipation, particularly with arunimab, which is Aimovig, but generally they're quite well tolerated. And this is just some of their data. These are patients who had on average 10 to 15 headaches per month, that they can really reduce the headache days by on average about 7. And they also decrease the intensity of each of the headaches. Let's skip this for now. The one thing that the American Headache Society has said is that they do believe that these medicines should be used first line. Usually patients have to fail 2 other preventatives before they're allowed to be on this. The American Headache Society does not believe this needs to be the case forever, but because these medicines cost on average 10 to 30K per year, it's a lot of the insurance, that's a lot of the gating on this, but there are some people who are able to get onto it first line. Then the other things that patients may choose to use if they come to clinic are we do Botox for migraine. Botox was inadvertently found to be helpful for migraine. The thought is actually that it actually helps block CGRP from being released because it stops the vesicle from being able to leave the nerve, and that's how it's worked all along. And we can do this for patients every 3 months, and they can have significant migraine improvement. We do GON blocks, and then there's a machine known as Cephaly, and there's other types of machines that essentially do electrical stimulation and desensitization of the upper branch of the trigeminal nerve, which is one of the places where migraine pathophysiology starts, and can be used either acutely during a migraine to stop it, or prophylactically for 20 minutes a day to help decrease migraines too. And there's some good data on that also. For time, if there's questions, I'll go over medication overuse headache, and then migraine management in pregnancy, including medicines to avoid. But one thing I wanted to focus on is when to refer to neurology. I think anytime there's any red flag symptoms, definitely want to refer. If there's any diagnostic uncertainty for either a primary or secondary headache or one of the tricephalgia syndromes or cranial nerve syndromes, definitely send them our way. Or if they're having refractory headaches so that you've tried 1 medicine or 2 medicines and it's not helping, or they want to try a procedure or something non-pharmacologic. But a lot can actually be done in PCP clinic too. So for take-home points, that first headache of life, always pause and assess for secondary causes, even if it feels slam dunk for migraine, and to remember SNOOP4. That evidence-based inpatient management migraine now includes anti-dopaminergic agents, NSAIDs, IV fluids, and nerve blocks. I'm curious to see how many institutions are going to work on increasing GON block access. We're thinking about that ourselves. For CGRP targeting therapies, they're new and they're useful for both abortive and preventative options. And we're trying to move them towards first line, especially since they are so migraine specific, but we'll likely have to wait for a few insurance and other hurdles to get past. Escalation decisions are driven by headache burden. It's not necessarily the number, it's how much it's affecting someone for what abortive we choose and what preventatives we use. And that neurology referral is a great tool for consideration of alternate agents or multimodal care. Thank you so much.
Thank you, Mark. That was terrific. You stand up here. Not releasing you just yet. For Lewy body, it looked like, is it a diagnosis of exclusion that you're ruling everything else out and you're left with it, or are there any positive tests for it?
Yeah, for Lewy body dementia, there's definitely positive tests for it. Not so much biomarker tests, but things clinically that we'll find. If patients start off with, patients with Parkinson's will get dementia. Other patients will start off with dementia and then get Parkinsonism. If they start with the dementia more than 2 years before the Parkinsonism starts, we're usually concerned for Lewy body dementia. And the three hallmark features that a patient will note is that they'll be talking to someone and they have very fluctuating awareness. So they'll be in the middle of a conversation and the patient will just stare off. You almost may think they're having a seizure. And then 5 minutes or 1 minute or 30 seconds later, just come completely back. The second is really those well-formed visual hallucinations, which is helpful to know because it's very different than the auditory hallucinations we frequently think about with a lot of psychiatric illness, that they'll have very formed visual hallucinations and usually at least one sign of Parkinsonism, whether that's a tremor, some of the gait instability, or some rigidity. Mm-hmm. So the combination of those three are the positive signs that we look for diagnosing.
And I was left still a little bit unsure when you send the Alzheimer's blood test.
Yeah. So for the Alzheimer's blood test, I think it is likely going to be most useful for patients who say they have a lot of vascular dementia or they have a lot of white matter signals from like maybe prior strokes, but a few things look like Alzheimer's and they have a lot of memory complaints and then either their MoCA or other neuropsychiatric tests looks like Alzheimer's. I think in that case, it can be helpful to kind of help tip them one way. In terms of the medications that we use, like donepezil and memantine, donepezil actually can be used for many different dementias, so it might not affect the treatment there. But if it's a family that was interested in potentially an anti-amyloid therapy and was wondering, I don't know if I want to put my family member through a PET scan or CSF studies, then that might be a good way to help triage that first decision to say, doesn't really look like Alzheimer's or does, so you can either continue down that route or we could take a pause here.
And I'll ask one more, then we'll open it up. Have we gotten closer to figuring out what exactly is going on in a migraine? It seems like there are medicines that are blocking nerves. There are medicines that are doing something with the vessels. What's actually the pathophysiology?
Yeah. The thought is still that there's cortical spreading depression that comes from different parts of the brain, likely the hypothalamus. That's why people first will normally feel fatigue or tired or something else. They get the cortical spreading depression, but it's really the trigeminal nucleus that turns on the system. And when it turns on the system, it then releases this calcitonin G related protein, which then affects mast cells, which start the inflammatory cascade of migraine, other nerves that are just nerves of pain, and then also the vasodilation of some of the blood vessels, specifically the ones around the meninges. And anytime the meninges are stretched, pulled, tugged, that's really bad pain. So it's likely that trigeminal nucleus starting that cascade causes the migraine, and it can go in different directions, which is why people's migraines are different. But why the hypothalamus starts that whole process, we don't know.
Amazing. Open for questions.
I have a question.
Go for it.
I was wondering, in the monoclonal antibody treatment for Alzheimer's, those frequent MRIs, is that to look for like early ARIA pre-symptomatic, or kind of like how does that change management?
Yeah, so they're used to look for ARIA after each infusion. For donanemab, since we know that 30% of patients get it, they actually increase the dose of medicine for the first 4 months. And then if they have a few microhemorrhages, but no symptoms, they may say safe to continue. But if there's a lot of new microhemorrhages that come up, even if the patient's not asymptomatic, they may say, let's hold back on this patient continuing. The other thing is that especially as patients do continue, if they ever do get hospitalized and have more, you want to be able to have a relatively recent baseline related to one of their prior therapies to know how much is new from this versus how much you need to do additional workup. But it's pretty frequent. And in some of the trials, they actually had patients, some of them get 11 or 12 MRIs. And you can imagine a patient with dementia, there's a big cost weight benefit of doing those kinds of studies while you're trying to slow down the disease by 20 to 30%.
Yeah. We'll get a mic back here. Say who you are.
Hi, I'm Liv with Hospital Medicine. In the SNP4 mnemonic for systemic, does that mean that anyone who has malignancy and then has a new headache gets a workup? And if it, how often do you do it if they keep, or endocarditis or whatever?
Yeah, I think for the SNP mnemonic, if it's a new, I think some people would say that new headache MRI. That's how some people think about it. I think that new headache CT scan can be okay in some cases, but new systemic illness with a headache that they've not had before definitely needs to be worked up with an MRI image. If it's that they have migraines and they have a new systemic illness, but they feel like they're still having their migraine, then you probably don't necessarily need to expand at that point from the S perspective.
In Alzheimer's, are we closer to understanding, is there some systemic problem with amyloid that somehow could be figured out early before it starts depositing the brain, or is it something local going on with the brain's handling of amyloid? Do we understand that any better?
I don't think we know a lot better. I think that I always, as a neuromuscular specialist, I see amyloid in so many different organs now too. We don't know why it chooses to deposit in the brain earlier. There is a slide I had that shows that there is some change in tau that happens pre-amyloid, and that some people, there's a gene, the ApoE gene, that increases the risk of people having Alzheimer's disease and developing amyloid plaques. So we always say that there's some kind of environmental genetic match that happens that starts the process, but as to why we're still a little bit upstream in terms of stopping the amyloid, but not stopping it from even hitting the phase of starting to accumulate.
Can you imagine that happening at some point, that we can figure out someone who's at risk for amyloid and deal with the protein before it starts depositing?
So interestingly enough, one of the false positives that you can get from that p-tau test is that the p-tau can raise well before any other syndromic component can happen. So there are using that test to be able to catch a few people who might develop Alzheimer's in the future, even though it's not as good in that context. But I do think that a lot of therapies are now pointing towards how to stop that cascade, since we know that it at least is upstream.
Great. Any final questions? Yeah, Alan.
Thanks. Hi, Alan Trudell, Internal Medicine. I manage a lot of Alzheimer's in my outpatient practice, and I've followed this sort of guideline of starting the donepezil relatively earlier. The problem is when I wait to start amantadine, it's often too late. It's kind of like these patients, I don't really see much benefit. So should I be starting that earlier? Would you suggest starting them together at an earlier stage?
Maybe not necessarily together at an earlier stage. I think that donepezil still works best in that first time that they're losing some form of IADL. What I think that where moderate and severe is not necessarily the line between I'm just about to go to need either additional help or need to live in a different type of setting. It's probably slightly before then. So once they're starting to need more help just in general, they're probably already at moderate, and that's probably an appropriate time to start.
And maybe final question, a lot of this, some of the therapies, nerve injections, Botox, do you guys do that? Do neurologists do that? Or who's actually doing all these things?
Yeah, so for Botox, neurologists can do this, GOM blocks, neurologists can do this, but pain management also does this, and they oftentimes do it with, at least at this institution, a much shorter waiting list. So they're also available for it. And then for the neuromodulation devices, those are oftentimes done specifically from the headache center across all three sites. But everyone can do it. And technically even a lot of ED doctors are doing this too, and some of these things. Right. So
we have actually a couple of questions online. Because I decided to bring it up because there are multiple questions about lithium in Alzheimer's disease, some data showing it prevents or slows the onset of Alzheimer's disease. Not something I'm familiar with, but I was wondering kind of what the thought is with that in the neurology world.
Yeah, I've not seen so much of that data, so I'm happy to look it up and then get back, but I've not heard that pick up as a big signal.
One more.
Yeah, the other question was about magnesium oxide, and does it have to be that particular formulation or another magnesium is okay too?
We typically use magnesium oxide, but other formulations are fine, usually around 400 milligrams, but we do know the side effects of magnesium oxide. So other forms are fine too, as long as they get the magnesium.
Great. Mark, thank you so much. Really appreciate it.